Hey everyone! Emergency veterinarians often reach for N acetylcysteine and vitamin K when managing acute liver failure in dogs and cats. In today's video, we'll take a deep dive into their use. We'll walk through current guidelines, key research findings, compare dosing protocols across species, and explore the controversies that surround both treatments. The goal is to give you a more refined, evidence-based framework for managing acute liver failure in veterinary patients. Let's start with N-acetylcysteine, or NAC for short. NAC is a modified form of the amino acid L-cysteine. Its primary role as a hepatoprotective agent comes from its ability to replenish intracellular glutathione, or GSH, which is critical for cellular antioxidant defenses. Beyond that, NAC also has direct antioxidant effects, cytoprotective properties, and anti-inflammatory actions. It's known to reduce pro-inflammatory cytokines like TNF-alpha, IL-6, and IL-1 beta. In human medicine, NAC has a long-standing and a well-established role. Its efficacy in acetaminophen-induced liver injury is undisputed. It is FDA approved for this indication, and when given within 8 hours of ingestion, NAC can prevent hepatotoxicity with nearly 100% success. So, what about acute liver failure that isn't caused by acetaminophen? Is there evidence to support the use of NAC in that setting? In 2009, a randomized double-blind trial by Lee et al. Enrolled 173 human patients with non-acetaminophen acute liver failure, including etiologies like drug-induced liver injury, viral hepatitis, autoimmune hepatitis, and ischemia. Although overall survival wasn't significantly different between NAC and placebo, transplant-free survival was notably better with NAC, 40% versus 27%. In patients with early coma grades, transplant-free survival improved further, 52% versus 30%. This study significantly influenced clinical practice. In 2021, a meta-analysis by Valad and colleagues reviewed 7 studies involving 883 patients. NAC was associated with better outcomes. The odds of overall survival were 77% higher compared to those who didn't receive NAC. And this corresponds to an odds ratio of 1.77. For transplant-free survival, the odds were nearly 3 times higher with an odds ratio of 2.85. Even post-transplant survival was improved with an odds ratio of 2.44. And patients in the NAC group also had shorter hospital stays. By 2023, the acute liver failure management guidelines suggested the use of intravenous NAC in non-acetaminophen acute liver failure, particularly in early-stage disease. As a result, NAC has become a widely used component of supportive care for a broader range of acute liver failure patients in human medicine. The standard IV protocol in humans starts with 150 mg per kg loading dose over 1 hour, followed by 12.5 mg per kg per hour for 4 hours, and then 6.25 milligrams per kg per hour for additional 6 to 7 hours. There's also an oral option, a 140 mg per kg loading dose followed by 70 mg per kg every 4 hours for 17 doses. However, it may cause nausea and vomiting in some people. In veterinary medicine, NAC has been studied in specific toxicities as well. For acetaminophen-induced injury, it remains the treatment of choice in both dogs and cats. In a feline study, oral NAC at 100 mg per kg effectively prevented or treated liver damage and methemoglobinemia when given concurrently or 4 hours post-exposure. Kai et al. 2015 experimental study investigated how N Acetylcysteine or NAC protects against carbon tetrachloride-induced liver injury in rats. Researchers found that NAC treatment significantly reduced liver enzymes and oxidative stress markers in this experimental research. Although no randomized clinical trials have been conducted in veterinary patients, NAC is commonly used empirically for a range of hepatotoxins in dogs, including xylitol, aflatoxins, blue-green algae, and sago palm, due to its glutathione replenishing and antioxidant properties. It has also been used in severe hepatic lipidosis in cats. In VetMed, a commonly used IV protocol was extrapolated from the original human oral protocol, and it starts with a 140 mg/kg loading dose, followed by 70 mg/kg IV orally every 6 hours for at least 7 additional doses. In cats with hepatic lipidosis, the protocol typically involves an initial 140 mg/kg IV dose, followed by 70 mg/kg every 12 hours. It's also important to note that when NAC is given intravenously, it should be diluted to at least a 5% concentration, equivalent to 50 mg per ml, and administered through a 0.2 micron filter. It should always be given slowly, over at least 20 minutes to minimize adverse reactions. Oral NAC, while viable in some settings, may be poorly tolerated. It often causes nausea and vomiting and is notoriously unpalatable, especially in cats. Therefore, nasogastric administration may be required if oral route is preferred. Additionally, activated charcoal can interfere with NAC absorption, so it's best to separate their administration or start with IV NAC. In cats, NAC appears to be cleared more rapidly than in humans. A feline pharmacokinetic study suggests that more frequent dosing or adjusted IV protocols could be considered, but no clinical research was done on that topic. One cat vomited within a minute of IV administration. In addition, anaphylactic reactions to NAC have been reported in dogs and cats, so its use is not entirely without risk. Overall, while the veterinary evidence supporting NAC in non-acetaminophen-induced acute liver failure setting is still developing, the human data offers a compelling rationale for its use. So here's my clinical takeaways on the use of NAC in dogs and cats with acute liver failure. First, NAC is a critical antidote for acetaminophen toxicity and should be administered immediately. Second, human studies show a strong signal for improved transplant-free survival in non-acetaminophen acute liver failure, making the case for its use in veterinary patients with acute liver failure highly compelling. In addition, experimental studies in rats have shown that NAC can be beneficial in toxic liver injuries beyond just acetaminophen. So, until more veterinary-specific data become available, I will continue using NAC in dogs and cats with non-acetaminophen acute liver failure. Pre-treating with antiemetics like meropenem, especially in cats, can help minimize gastrointestinal side effects. And of course, it's important to monitor for potential hypersensitivity reactions, particularly when administering NAC intravenously. Now, let's tackle the use of vitamin K in managing acute liver failure in dogs and cats, starting with a brief look at the human literature. Vitamin K is a fat-soluble vitamin that plays a critical role in the so-called gamma carboxylation of clotting factors 2, 7, 9, and 10. This process is essential for these factors to bind calcium and function properly within the coagulation cascade. If I had to summarize its clinical relevance in human liver disease, I would quote the title of a letter to the editor. Vitamin K is okay in kids and cholestatic patients. In patients with cholestasis, impaired bile flow reduces the absorption of fat-soluble vitamins, including vitamin K. This can increase the risk of coagulopathy, particularly when compounded by impaired hepatic synthesis of clotting factors. Human newborns are also prone to vitamin K deficiency due to several factors, such as minimal placental transfer, low hepatic stores at birth, immature gut flora, and the low vitamin K content of breast milk. That said, in human acute liver failure, true vitamin K deficiency is relatively uncommon. Multiple studies have shown that vitamin K supplementation, whether given orally or parenterally, typically does not result in meaningful improvement in relevant coagulation parameters in most patients with acute or chronic liver disease. That's because the coagulopathy is primarily due to reduced synthesis of clotting factors by the damaged liver, not due to a lack of vitamin K itself. In a 2005 randomized double-blind trial, 49 adults with severe acute liver failure were given either IV or oral vitamin K1 or placebo. Only 27% had biochemical evidence of subclinical vitamin K deficiency at admission. A single parenteral dose of 10 milligrams vitamin K corrected the deficiency in nearly all human patients, while oral absorption was unreliable, failing in 80% of cases. These findings suggest that when vitamin K deficiency is suspected, one parenteral dose is usually sufficient, at least in people. The 2023 Human Acute Liver Failure Guidelines do not recommend routine vitamin K supplementations for all human patients. That's because coagulopathy and ALS involves more than just factor deficiencies. It also includes platelet dysfunction, increased fibrinolysis, and altered thrombin generation. As a result, vitamin K supplementation should be reserved for cases of confirmed or suspected deficiency. That said, in veterinary medicine, there are no formal consensus guidelines, but it's common to see recommendations for empirical vitamin K1 administration in cholestatic patients, especially cats. A typical protocol involves 0.5 milligram per kg subcutaneously twice daily for 3 days, followed by weekly maintenance dosing. Here are my clinical takeaways regarding vitamin K use in veterinary patients with acute liver failure. Vitamin K deficiency is probably uncommon in patients with acute synthetic liver failure, but it can occur, particularly in those with significant cholestasis, such as patients with markedly elevated bilirubin, ALK-Phos, or GGT levels. And short course of parenteral vitamin K may be appropriate when deficiency is suspected or cannot be ruled out, especially if a patient is bleeding or an invasive procedure is planned. And finally, oral vitamin K is unlikely to be effective in liver failure patients due to poor intestinal absorption. All right, I hope you found this video helpful, and I'll see you next time. Bye-bye.